50% of our population are going to go through this at some point in their life. And when something like this, again, impacts their cardiac health, their bone health, their brain health, their genitourinary health, like more people die from urinary tract infections because of the changes in hormones than is what is necessary. I mean, we spend over $1 billion every year on recurrent urinary tract infections, and we know that vaginal estrogen, vaginal estradiol, can improve recurrent urinary tract infections by over 50%.
That was a quote. You just heard it from my next guest, Aleece Fosnight, a board-certified physician assistant specializing in sexual medicine, women's health, and urology. She's also a medical advisor at Aeroflow Urology. And in today's conversation, we're focusing on pelvic floor health as well as bladder health and tackling the controversy around the current climate and headline news on black box warning labels for vaginal estrogen. In this episode, you will learn about the importance of pelvic floor health, especially after childbirth and in menopause, of course, and the need for proactive pelvic floor evaluations and therapy. You'll also learn the linkage between menopause and urinary incontinence as estrogen declines, and learn about some lifestyle recommendations to help address urinary incontinence. And most importantly, have better understanding and clarity around these warnings that are not supported by evidence when it comes to low-dose localized vaginal estrogen. This unnecessary alarm is causing way too much confusion and anxiety among women who might otherwise be benefiting from some of these therapies. And so in this conversation, Aleece encourages listeners to get informed and have informed conversations with their healthcare providers and oncologists regarding the safety and efficacy of vaginal estrogen. Aleece also emphasizes that localized estrogen is indeed safe, does not increase the risk of breast, endometrial, or ovarian cancer, and does not worsen breast cancer recurrence. And she specifically notes that the recent guidelines support the safety of vaginal estrogen with very few, if any, contraindications for its use. I absolutely love it when my guests come on and disrupt the narrative around women's health, shake things up, and encourage women to get educated. After all, knowledge is power, but the application of that knowledge, that's wisdom. But before we begin, here's something you need to know about Aleece. Aleece Fosnight has 14 years of experience in private practice in Asheville, North Carolina, and is known for advocating for open conversations around female sexual health and combat the stigma around urinary incontinence, which is often mistakenly viewed as a normal part of aging. Aleece takes a trauma-informed approach to pelvic floor assessments, focusing on patient consent, comfort, and comprehensive evaluations of pelvic floor muscles. In 2019, Aleece opened her own private practice, the Fosnight Center for Sexual Health, and she's also the founder of the Fosnight Foundation, which is a nonprofit organization dedicated to the education and training of professionals in the sexual health field and providing funding for access to healthcare services in her local community. Please join me in welcoming Aleece to the Menopause Disruptor podcast. Welcome, Dr. Aleece, to the Menopause Disruptor podcast. Here to talk about a very important topic of urinary incontinence and other issues that we really need to be paying attention to for our good vaginal health in menopause, premenopause included, and of course the years beyond. So welcome to the Menopause Disruptor podcast.
Thank you so much for having me. This is a huge topic near and dear to my heart. So it's exciting to be able to have a space to really dive in and to chat about it.
Yes. And I always like to start right away with what was your journey to lead you into this field of medicine as a doctor in the first place?
Yeah, well, it's an interesting story because it actually goes all the way back to my medical training at the University of Kentucky when we were doing a master's thesis on a topic, and we got to choose whatever we wanted to. And I knew that I had kind of a passion for women's health, but was really struggling with a topic. All of my colleagues were doing orthopedics, sports medicine, diabetes, and I was like, oh, this doesn't excite me. And so I was actually talking to my mom on the phone when a Viagra commercial came on the television. And I thought, oh my goodness, if there's a blue pill for men, there has got to be a pink pill for women. And when I started digging into the research, there was not. And I got really pissed off. And so I was like, this is an important topic. We're learning about penises and prostates in our training, but we're not talking about the clitoris or female pleasure. And so this is something we need to do. So when I got into the research, all of my articles were coming from urology journals. And it's interesting because I actually worked for a urologist when I was in high school. So kind of full circle coming back. And so that led me into my urology love of talking about pelvic health, bladders, talking about important issues like sexual health, sexual wellness, importance of optimizing pleasure for women. And so I've been working in the field for 14 years now and opened up my own private practice 5 years ago in Asheville, North Carolina, to continue to really focus on women's sexual health.
Oh, that is such an important field of medicine, field of women's health in general. But I applaud you for really stepping up and recognizing that there was a gap,
Correct.
filling that gap with your desire to make a difference. And so, just why does menopause trigger incontinence in the first place?
So, when we are looking at the role of menopause in our life, the definition is actually from the Menopause Society when you are a year after having your final menstrual period. But
Mhm.
for me, that definition needs to include so much more. And it is the decline of estrogen, mostly from the ovaries, where we start to see those symptoms. And as a reminder, estrogen has over 400 functions in our body, and in particular in our pelvis. And one of the fun, interesting facts that we don't often talk about is the fact that embryologically, the top part of the vaginal canal and the bottom part of the bladder and the urethra are made out of the same tissues. So when we think about menopause and the changes that are happening in the pelvis, it's a much more inclusive term to use genitourinary as kind of the umbrella term that we would use. So it's not just impacting the vagina, it's impacting the bladder as well. And so as, yeah, those estrogen levels are coming down and even testosterone, as those levels are coming down, there's a lot of changes that occur in the lower urinary tract. So we have decrease, changes in the pH, changes in the microbiome, thinning of the supporting tissues, and that also includes that urethra. So now it becomes more irritated. It becomes more that we have to go to the bathroom more frequently. Our muscles are not as strong as they once were in the pelvic floor. And so that urethra isn't as compliant either. And so there may be some leaking or urgency that occurs with it.
So, is there a prevalence for women, though, just to still not talk about it, let alone go and get this checked? And I'm talking about women even as early as 30, perhaps 35, or we still think, we might just be in the reproductive phase. Many women may not have even started their family. And so when that happens, it's often chalked up to something else not related hormonally. Is
Correct.
there more of a prevalence for women just to avoid it? And what can we be doing to start informing women early enough to always have that check, just like a pap test, to still have our urinary, genital urinary tract functioning optimally?
The misconception is that any kind of urinary incontinence is normal. And I love to break down this myth of it is not normal, but it could be common. And so
Okay.
there's a difference, right? That we should not accept the fact that what we are dealing with and what we're feeling is a normal process of where we are in our lifespan, but it is often been chalked up and dismissed to women. Oh, you've had two babies. Oh, you're just not focusing on your pelvic health. Oh, you're just in menopause, that this is something you just have to deal with. And that's not true. This is something that, if recognized early, can be treated and not be a disruptor in your life, in your activities of daily living. And so oftentimes women just chalk it up that this is just happening. And while we are having more conversations around bladder health and pelvic health, there's still a lot of stigma and shame and embarrassment that go along with this. Is that am having to change my clothes because I just peed my pants. And nobody really wants to talk about this, even though it is a normal function in our body.
I would say this is a perfect time to break for a word from our sponsors. Guess what? You, my listeners, are my sponsors. That's right. I would love it if you could support the show. Helping me will help bring these amazing episodes to you each and every week, just packed full of information to help you on your menopause journey. And to support the show, all you have to do is go into the show notes and click just above where you read Meet Your Host. In green is Support the Show. You click on the button and it'll bring you to a page where you have the option to donate monthly, 3, 5, 8, 10. You can be a loyal supporter for as long as you want with recurring fee as little as $3 a month and opt out at any time. Each investment goes directly back into producing episodes with even better content, improved audio quality, and will go a long way in bringing great guests onto the show. Oh my goodness. So what are some of the different types, if you will, of incontinence that show up during perimenopause, even in our postnatal years as well, soon after childbirth? What are the different types and how can we look for them? Just the minor leakage is one thing, but what are some of the other key symptoms to be on the guard for?
So there's three common types of urinary incontinence that we see in this time frame. There
Okay.
are more in general, but ones that are specific to this are going to be stress incontinence,
Okay.
urge incontinence, and then a combination of both. So you can have dual or mixed incontinence. So stress incontinence is the type of leakage that you have when you cough, sneeze, laugh, exercise, move your body. That a lot of times is secondary to the urethra not having as much support as it once did. The
Mm,
second one is urge incontinence. That's the one where you got to go to the bathroom very quickly. You feel this sudden need to go to the bathroom, and on your way to the restroom, you're having a little bit of leaks on your way there. We sometimes can also see some urinary frequency that is associated with that urge incontinence. And then the third one, again, is a combination of both of those. So you may have an experience both leaking when you cough and sneeze, and then the sudden urgency to have to run to the restroom very quickly.
yes. And I always blamed it on having my child. I said, it's the reason why I pee my pants. Yeah.
Yeah. And while pregnancy is a big risk factor, and then mode of delivery. So a lot of people think that they can get by with having a C-section, right? And that's not always the case. It is the fact that you're pregnant, and that's putting a lot of extra pressure on your pelvic floor. But we can reverse and improve those changes that have occurred. I was very fortunate enough to do one of my rotations while I was in school over in Europe. I was there with a urogynecologist. And one of the very first things that I learned while I was over there is everybody postpartum, no matter mode of delivery, gets to go to pelvic floor therapy. Like it was
Um,
just this automatic referral over to a pelvic floor therapist. And
Unbelievable.
we see a lot less urinary incontinence and pelvic floor prolapse. And I'm over in Europe, and my guess is that this is why. So I don't understand why it hasn't fallen suit here in the United States, but I encourage so many women to not just go after delivery, go before you get pregnant, have somebody evaluate your pelvic floor ahead of time. It's so important.
And that's so funny because we just don't think of pelvic floor health in
Yeah.
general overall health in terms of keeping those muscles nice and strong. And, we'll go to the gym to exercise the muscles of the body. Pelvic floor often gets put in the background, much like you had said, because no attention has been really drawn to it here in North America. And I applaud the UK for leading the charge. They seem to be ahead in a lot of women's health issues, and we're just playing catch up. So, again, thanks to the like of yourself, we're starting to move that yardstick in the right direction. But now that we've talked about the pelvic floor, let's dive in. What should we be doing now, early enough, to keep our pelvic floor strength up, through all of our stages of our lives, not just pregnancy, but obviously going right through to postmenopause years.
Absolutely. So, first of all, is recognition. I think that that's
Mm.
the biggest thing is that you do have a pelvic floor, right? And what does that mean? And what are the muscles involved? When we see our muscles and we see things changing, like we go to the gym and we're doing bicep curls, or you're working on your triceps, and you can see that definition. and that change and the strength, it's much easier to comprehend. But when we don't see our pelvic floor muscles, sometimes it's a trickier one to be like, wait, we have muscles there, and what do they do? But we can definitely see a change when you are focusing on those pelvic floor muscles. So you can see strength, especially if you're symptomatic, meaning that, again, if you have incontinence or you're having pain with penetrative or sexual activities, or even defecation. So we have to remember, right, the pelvic floor is essential to kind of those three things. So I love my pelvic floor therapist colleagues because they always explain it. They work with patients to help them, pee, poop, and have sex better. So
Oh, perfect.
I know, I love it. Yeah. And I really resonate with that because we should have some humor and laughter around the pelvic floor, especially again when there is, again, so much shame and stigma around it. But having a pelvic floor physical therapist really evaluate your pelvic floor, I think is one of the first things that you can do to see how is your pelvic floor functioning. I think there is a unawareness, and we take for granted. That's what I meant. We take for granted that our pelvic floor is fine, right? Usually in our 20s or 30s, we're not really thinking about those sorts of things. But really, we're seeing a lot more people sitting. They're not as active as they once were. Most jobs are now can be remote or virtual from at home. Also, with increased anxiety, there actually can be more tight pelvic floor muscles. And this is a great opportunity to talk about the difference between tight pelvic floor muscles and strong pelvic floor muscles, right? I think of tight muscles, and I explain this as like your shoulders. If your shoulders are really tight, right, you can't go do and function the way you want to. But if you have neutral shoulders that are strong and can engage when you need them to, that's the type of muscle that you're wanting. So same thing in your pelvic floor. So I don't like a lot of times when we interchange those words of tight and strong. But
Yeah.
you can have somebody evaluate that for you so you can see. It's really more difficult for you to evaluate that on your own. And the other thing that I really value from my training doing my rotation over in Europe was that the physician that I was working with actually assessed people's pelvic floor. And I was like, this is fantastic. I wasn't taught this. You do your pelvic exams and you're going straight for that cervix and doing paps and then you're done. But we forget that there's so much more beautiful anatomy between where the vulva and where the cervix is. And that includes, again, the vulva and the clitoris and the pelvic floor muscles. So I really took that with me so that when I was doing pelvic floor examinations or doing pelvic exams, that I was also assessing the pelvic floor muscles too, and being really cognizant and mindful of what I'm looking at and what I'm feeling and how the patient is reacting as well.
Okay, so how do you conduct an assessment?
Yes, absolutely. Well, first of all, I get consent and permission from my patients. That
Okay.
is we do trauma informed pelvic exams. Unfortunately, female identified individuals have a lot of trauma, both medical trauma and sexual trauma that in their histories. And so we talk about it ahead of time. I always interview my patients clothed first before I actually do the pelvic exam. How I walk through my patients with it is I will let them get into that lithotomy position and I ask permission. Let me know when it's okay for me to uncover. So I'll uncover when they give me that permission. I always touch their inner thigh. And there's a trick to this. Not only does it help to create trust with my patient, right? They know my touch, right? And I'm not going straight to their genitals, but I also get to see if there is tension in the adductors and those inner thighs as well. And we can often find that if there's tension in those inner thighs, that you're going to have tension in that pelvic floor also. So I will palpate down the inner thigh. I will go up over the mons or where the pubic bone is, and I'll go up the other thigh. And then I'm palpating actually externally over the vulva, so over the labia majora and the minora, because that's your first layer of your pelvic floor muscles. You've got three major layers to your pelvic floor muscles. So that's your superficial one. And then I will go look in all the nooks and crannies, is what I tell my patients. So I'm peeling back the clitoral hood, I'm peeling back the labia to look in all of those crevices. And then I will take one finger and do a monomanual exam. So if we're here with the vagina, right, I'm going to just touch here on the outside and get right to that vaginal opening. And I'm really assessing stretch, elasticity, and is there any pain? I'm also looking at the color and consistency of the tissues too to see if there's any hormonal changes. This is right really key when we're talking about any sort of hormonal change, whether that's perimenopause, menopause, lactation, anything, or people who are on birth control pills that maybe that is suppressing their endogenous hormones, that can also cause changes to the pelvic floor and to those genitourinary tissues. So there's a category and a lot of processing that I'm
Oh,
doing just with this very simple exam, but it's so
very-
important.
yeah.
Yeah. And then I go a little bit farther in to check kind of the median part of the pelvic floor muscles. That is a lot of times where who have penetrative pain with sexual activity will say, oof, yeah, that's uncomfortable, that's painful. And what I'm looking for there too is trigger points. It's the same thing that we would look for with a massage therapist, like in our shoulders, right? Those little knots that we feel, they actually manifest themselves in those pelvic floor muscles because they're muscles. Yep. And then I go into those deeper muscles, which are important for the bladder, which is like your coccygeus muscle. That one's going to be really important as a kind of hammock sling to support the
Yeah.
bladder, as well as around that urethra as well. So, and a lot of people go, gosh, that must take you a really long time to do, Aleece. But really, I actually timed it. It takes me not more than 30 extra seconds to do that than what somebody else would do on a regular exam. So it doesn't add more time to my day or delaying patient care. It actually is a really easy, quick thing that you can do.
Yeah. Yeah. Time spent on observation or testing, examining is probably time saved in dealing with an issue that could be prolonged and worsen. And
Yep.
on that note, if it goes unchecked, because let's face it, not all of us are going to have you as our doctor who's very
Right.
thorough and very gentle and knows what to look for. So when these things do go unchecked, because we'll go in for a regular PAP, it's incontinence is not normally the focus unless we bring it up, and
Correct.
may get a referral to a physiotherapist who specializes in pelvic floor health. So what will happen if it just goes on a little bit prolonged? Like, does it mean incontinence could become a prolapse, for example?
It definitely could.
Okay.
What we typically see as the trajectory of incontinence, pelvic health happens, we know over time that those muscles continue to get weak, that
Hmm.
hormonal changes continue. This is one of the biggest things that I was really excited about to see and read in the American Urology Association's guidelines that just came out in April of 2025, specifically talking about genitourinary syndrome of menopause.
Yes.
When menopause is talked about, often think about hot flashes, vasomotor symptoms, right? Irritability, and that eventually will go away. We'll get through this process and we'll get to the other side and we'll be okay. The difference with genitourinary syndrome of menopause is that it's chronic and it's progressive. It is not going to get better. We have to intervene, or we're going to see recurrent urinary tract infections, increased urgency and frequency, burning with urination, pelvic organ prolapse, pain with sexual activity. This is not going to get better. We are
Oh,
not doing, our patients any good if we don't ask. And so I love to also empower patients to say, I heard this on a podcast or I read this on social media. Like, bring it up. I love
yeah.
it. I encourage my patients love me because I leave this creative space for them to talk, right? It's us working together as a team. And I think it's really essential for providers to do that, is to leave this open space for you to have a great productive conversation. It allows you to talk about a concern that they have, debunk some myths. There's not always good information that's out there either. So it creates an opportunity for us to really dig into it and why that's not maybe the best information. Talk about the evidence and then say, I'm glad that you brought that up. Is that a big concern for you right now? How can we address it? What do you want to do about it? Because this is also a team, right? A partnership of us working together to find what's the best thing we can do for you as an individual.
Right. Yes. And now that we have these journals, these medical journals, and the research backed by science,
Hmm.
literally print it off and hand it to our doctor. And on that note, I mean, there's still such a growing population. And I say growing because we still have a lot of young and new doctors entering into the field of family medicine that still have not received the education, let alone the doctors that are still in healthcare have not ever received information. And even though the ghosts of the 2002 Women's Health Initiative have surely by now disappeared into the ether, they don't. It lingers. And that
Mhm.
just is like a really bad rumor that just keeps passed on and passed on, and the lack of education. So, as a doctor, as in your specialty, and you encourage your patients to share this information with their entire healthcare team, encouraging them, get educated, take the evidence, present your case to your doctor to sort of in hopes of achieving shared decision making in their healthcare plan. But then it's received with resistance, we will say, to push
Pushback. Mhm.
back.
Mhm.
Because, I mean, in a way, we're challenging a doctor's credibility and their experience by saying, your answer's not good enough. Here's what the report is. So, how would you encourage women to come up against these challenges?
Right. First of all, you've got to be able to find a provider that you feel comfortable with. And that's not easy. And by the time that most of my patients come to see me, they've seen 3 or 4 or more providers that
Mhm.
they've met with that resistance, just like we talk about. And until the medical community realizes that, again, it's a working relationship with your patient and that your patient's not challenging you. I'm glad that you brought that up because we see so much of that. Well, they're challenging my authority. And I'm like, oh my goodness, absolutely not. They're curious. They want to know information. They're thirsty for this information about what's going on with their body. And for years, we never talked about it. This is
Yeah.
the other thing that I get from my patients that I've heard with their interactions with other clinicians is that, well, this is just normal. You just have to deal with it. Menopause is natural. But so are flaccid penises, and we have Viagra and Cialis to help with those. We have science, right?
Yeah.
So we need to validate and understand how menopause is impacting people and the comorbidities that are associated with it. And
Ugh,
until we change the education from the root, right? This is, coming from the top down when the patients are coming into the office. We need to start at the bottom. We need to start at that foundational information and talk about menopause and why it is so important, right? 50% of our population are going to go through this at some point in their life. And when something like this, again, impacts their cardiac health, their bone health, their brain health, their genitourinary health, like more people die from urinary tract infections because of the changes in hormones than is what is necessary. I mean, we spend over $1 billion every year on recurrent urinary tract infections. And we know that vaginal estradiol, can improve recurrent urinary tract infections by over 50%. Yeah.
wow. Okay, Elise.
I know. I'm sorry. I'm getting really,
No, no, no,
really
no, no.
feisty here.
That's
Yeah.
the name of this podcast.
I
Disrupt,
love it.
disrupt,
Yes.
disrupt.
Totally.
Had
Yes.
to dropped a bomb.
Hmm.
Everything was going really swimmingly, and then nobody thinks about this. Urinary tract infections as a comorbidity, huge money being put into this healthcare area of healthcare that's being completely ignored, sidelined, forgotten about, dismissed. And then, of course, as women, our social construct has taught us to don't talk
Right.
about it. This is embarrassing. This is don't want to be feeling that shame. Holy cow. All right, this should be the headlines that should be going up in the news, not the ridiculous headlines
Correct.
that
I feel with you. Yes.
damage women's health, the history of it for far too long. Okay, wow. You have talked about vaginal estradiol. I think it's time that we start getting into this topic. I want to also talk about some bladder irritants, things that we can do from a holistic perspective in our lifestyle, of course, from what we consume. But let's talk about vaginal estradiol. Let's unpack it all for the listeners. Is it safe? Can we use it with regular, like transdermal or gel or a cream, estrogen and progesterone? And let's talk about all of its benefits.
When you are using systemic hormone therapies to help support you through your menopause transition,
Mhm.
what we don't get a lot of conversation around is the decreased permeability of systemic hormones into those genitourinary tissues. So while we think that by supporting our system and we're putting this estrogen patch on and we're, taking our testosterone creams and gels and we're rocking and rolling, it doesn't get to the genitourinary tissues. So you have to go locally. And that's another, like, again, myth that a lot of my patients come in thinking that they are okay because they're using a transdermal estradiol formulation. So you can definitely use both a systemic and a local estrogen formulation to help to support your body. And it's safe. And that's one of the things that I'm so happy with these guidelines, like I said, that just came out because they have that in there. There is very few, if any, contraindications for someone to not use vaginal estrogen. One of the biggest things that I always tell people that if you have any kind of abnormal uterine bleeding, abnormal vaginal bleeding, we've got to figure that out first, right? That's going to be the biggest thing. But we know that localized vaginal estrogen cream does not increase your risk of breast cancer. It does not increase your risk of endometrial cancer or ovarian cancer. It does not increase the recurrence or make your breast cancer worse if you are currently having breast cancer. Like we know that information. Everything is local. Very little of it actually gets absorbed systemically. So that's again the conversation that you should be having with your oncologists too. I had a wonderful appointment with one of my patients yesterday who has a history of breast cancer and has been very resistant to increase her use of vaginal estrogen cream. She wanted to use the littlest amount, but she was having recurrent urinary tract infections. She was having pain with sexual activity, just always felt kind of uncomfortable, even with sitting and doing other activities. And so I said, this was our appointment from the time before. I said, hear me out. Can we increase the frequency? Like, I'm going to meet you where you're at. I want you to feel comfortable. That's how you're going to be successful in this journey. But hear me out. What about using it more frequently? She was only using it about 3 times a week and
Okay.
just using the tiniest amount that she could with her finger. And we talked about it. She said, can I give it a month, Aleece? I'm going to use it every day. I do it to it for a month. And I saw her back. And guess what? She's so much better. She hasn't had a urinary tract infection in over a month.
So good.
She has less urinary urgency, no burning with urination. Sexual activity is much more pleasurable. And she also had an oncology appointment with her breast oncologist in the meantime, who absolutely blessed the vaginal estrogen cream and said, yes, do it every day. You are fine. The research, yes.
So good.
Oh
Oh,
my gosh. I mean, what an amazing feeling, not just for me, but for my patient. She feels better. And to have that, like, okay by her oncologist, there's this huge fear. She doesn't want to have a recurrence of her breast cancer. She wants to live. She's got kids, got a family, got a career, right? And so we don't want to do anything that's going to disrupt that. I have 2 rules in my practice. I always tell people, right? Do no harm. But the second one is whatever we do has to work. And so, that is where it was a beautiful process to see with her feeling so much better.
that is wonderful to hear that. And it's just prompted me to think, okay, so if we have women that are experiencing urinary tract infections at a young age, and we're talking pre-menopausal years, is vaginal estrogen, estradiol, safe?
If we have ruled out everything else that's a cause, yes, totally safe, completely safe. There's, again, very little, if any, negative side effects that go along with it. One of the interesting side effects is increased vaginal discharge. And when somebody has not had vaginal discharge in a really long time, and that vaginal discharge, let me say, is a normal thing, right? Our vaginas are self-cleaning ovens. We make about a tablespoon of vaginal discharge every single day. Like, it's okay to have a little bit on your underwear or on your pants. Totally fine. And so it's just creating that normalization of like, this is a good thing. This is the things that we want. But many women who are on birth control pills experience vaginal dryness and can have increased urinary tract infections. It's not always based off of like coital sexual activity, but it could be, right? And so those are the things. If we have ruled everything out, try a little bit of local estrogen cream. Like, it's not going to hurt for you to try it for a couple of weeks, see what happens. But most of the time, they're going to feel better. This is also the case after lactation. We also have a new terminology, right? Genitourinary syndrome of lactation. And this was something that I experienced after my first kiddo. I went for my 6-week postpartum checkup and I was like, all right, I'm totally feeling this dryness that my menopausal women are feeling. Can I do estrogen cream? And she was like, oh no, well, just give it a couple more weeks and maybe it'll get better. And I was like, but I don't feel good now. And so I did my own digging, I went back and asked for some estrogen cream. I was really nervous that maybe it was going to affect my milk supply. But again, it doesn't absorb very much systemically, and started using it and was like, oh my goodness, I feel so much better, right? I didn't need to have to give it another 6 weeks or whatever else. I didn't have to stop breastfeeding my baby. It was an
Oh,
option for me to use, and it didn't, like I said, impact my milk supply. Maybe different for everybody, but it's an option. So anything that is going to hormonally change the genitourinary system, no matter what it might be, women deserve to have local vaginal estrogen cream as an option.
I love that. That's the title of this episode right there.
Mm,
Women
mm,
deserve to have vaginal estrogen cream. Now, what is the difference between estradiol cream and estrone? Is there a difference?
there is a very good difference.
Yes.
So when we think about estradiol, estradiol is E2. That is the estrogen in your body that you make in your reproductive years. That's what helps to lubricate your joints, build collagen in your skin, give you those feminine characteristics, help to lubricate the vagina. As we go through perimenopause and menopause, the estrogen turns into estrone. It has a much higher affinity to those estrogen receptors, but is a weaker hormone. So you're not actually going to get the benefits that you would from the estradiol component. So I'm an estradiol girl through and through, and that's what I prefer.
Okay, so even a woman who's postmenopause
Oh, yeah.
should
Mhm.
be opting for an estradiol vaginal cream as
Ah,
opposed to estrone.
correct. Yes.
Okay. I'm going to have to be having a conversation with my doctor. I have an estrone vaginal cream. Now, I found, oh, just revealing so much personal stuff on my show. Oh my goodness. But
It
I found,
humanizes you. Yes.
yeah, it humanized me. And if
Mm.
I'm supposed to be here breaking down the taboos, well, then I better be a leader. I better be marching to the beat of my own drum. But I have found that initially it's like, oh, I'm seeing some success for the incontinence because this is why I needed it. I requested and worked with my doctor to enter into that decision. But then after a period of time, it's kind of like, well, it tapered off and then now it's just sort of plateaued, but there was no real, like, wow, I'm super excited about this. It's kind of like, yeah, well, it's okay. So I guess I have two choices: opt for an estradiol cream, or would I increase my frequency?
So you could do both.
Oh,
That would be okay. And you have the estrone cream right now. So utilize that. And that's why I always tell my patients, if you've got it, use it, right? And I think increase the frequency. And I will often do that with my patients who start to wane in their symptoms a little bit. Most of the time, we are talking to patients about using it frequency of like on a daily basis for several weeks, and then they can back down and use it maybe 2 to 3 times a week. Most of my patients, too, that are coming to me from a different provider are only using it twice a week. And while that can be helpful for some people, I find that that's just not enough for most. So
yeah.
increasing it to either every other day or 3 times a week can be really helpful.
Okay. That's great advice. So now let's talk about some other therapies that we can do naturally. One being aware of what irritating foods and beverages for the bladder. So what can we be doing to optimize bladder strength just through our simple lifestyle choices?
Well, first of all, when I have this conversation with my patients, I will talk to them about what are the things that we can do rather than take away.
Okay.
When we limit, a lot of times, or people think that we're taking away something that they really enjoy. It's not fun. It's not pleasurable. Yeah, coffee. Listen, I'm with you on that one. I love my coffee. It's a ritual for me in the morning, and I feel like it gets my day going. So rather than having necessarily to take something away, we talk about can we limit how much we're actually intaking. But the biggest thing, and I would again wouldn't be doing justice if I wasn't talking about water as a urology PA. Water is so important. Most people do not drink enough water. So when we think about the way that our bodies process through our kidneys and we're filtering out all of the waste products, if that is super concentrated and we have a lot more waste products in one volume, that can be super irritating to our bladder. So a simple thing you can do is just increase your water intake.
Okay.
Typically 80 to 100 ounces of water every day, unless there is another medical need for you not to have that much water, is really what we should be drinking. Most people are not hydrated. When we're drinking that much water, we also do want to talk a little bit about electrolytes because we can sometimes wash away those. So, little electrolytes in your water can be helpful. Usually, once a day is all that you need. But if we can dilute our urine and make it less concentrated, automatically you should have less irritation. But then, yes, the other things to think about are going to be yes, your coffees because it's got caffeine in there, your citrus, your spicy foods, chocolate. Oh, so the darker the chocolate, the better, though. It has less caffeine. So that's another way that you can get by with it just a little bit. Artificial sweeteners are going to be another one that I really try to avoid with patients or limit that. And then alcohol. Alcohol is going to be
Mhm.
another one that we want to limit. And for lots of reasons, right? Here in the United States, the US Surgeon General is really looking at putting a label on our alcohol of it causing cancer. We see a big increase of breast cancer and colon cancer with alcohol consumption.
Oh my gosh. Yes. Alcohol is just bad for many reasons. So now, that aside, in terms of what we can consume and limit, what are other things in terms of the strengthening the pelvic floor? We've heard about pelvic floor therapy and other treatments, and of course, the classic Kegels. Do they
Yes,
work? Are they effective? How should that treatment be applied?
correct. Most people don't know how to even engage their pelvic floor.
Hmm.
So, one of the things that I will encourage my patients to do, and it may feel a little foreign to you, but you could either sit on your hand or place one finger in the vagina. When you do that and you try to squeeze and lift, right? So, those are two things. It's not just squeezing around, we want to lift and pull up towards our belly button, right? It's usually what I'll say, but try to create an image, is what I
Hmm.
really try to tell my patients. So we want to squeeze around that finger and then lift that finger up into the pelvis, like towards our belly button. That is a great way to engage those pelvic floor muscles. If you are sitting on your hand, you can feel this like lift up from your hand, and then it coming back down is another way to know that you've actually engaged those pelvic floor muscles. Now, if you're sitting there and you feel bulging, right, when you're trying to lift, that means that you're not having that coordination with your pelvic floor. That's a great reason to go see a pelvic floor therapist.
Oh,
Or
yes.
if you're trying to squeeze and you're like, I feel like I'm squeezing, but it's just not lifting as much. You could have a tight pelvic floor. And so you're not getting as much contraction or shortening of that muscle because it's already shortened. So
Uh-huh.
you can't do a Kegel if a muscle is already tight. So that's
Right.
another reason to go seek pelvic floor assistance. And
Okay.
most of the time, you can go see them once a week for just a handful of times. The goal is for you to be able to do these on your own. So that's how you can engage those pelvic floor muscles. But we have to remember it's really your core. And this is kind of nipples to knees,
Mm.
is what I tell people, right? So it's your hips working together, your lower back, your abdominals, all of that is your core working into that. And if we're thinking about, again, more of our female identified individuals or people who have been pregnant, right? Those muscles in your abdominal walls can separate, and that's called a diastasis. That can happen. And when you have a weak core in that area, you could strengthen your pelvic floor all you want to, but your abdominal muscles are not going to help out. And so you could still have urinary incontinence, pelvic floor or organ prolapse, or even fecal incontinence can happen too with that. We often forget that those bowels are right there. And again, they are important too to make sure that your bowel movements are functioning well.
Like you say, without uncontrolled or, yeah,
Mm.
involuntary defecation.
Yeah, it happens actually more than what people think, especially up to a quarter of people with urinary incontinence also have fecal incontinence.
Is that right? That's
Hmm.
an interesting statistic. Okay.
Yes, yes. And a lot of it stems from constipation or holding bowel movements. Yes. So,
And women often have
mm,
constipation because this is a stress, an outcome of our stress,
yes.
holding everything in. And oh, wow, this is very informative. Now, what about some therapy, such as sound therapy, or what's the pelvic floor?
So, yeah, pelvic floor therapy, you might be thinking of some biofeedback
Biofeedback.
or, yeah, or some of the almost like a TENS unit where it
Yeah.
can help to stimulate. Yes. That can be really helpful, especially for those individuals that are struggling to find that connection between their brain and their pelvic floor. Biofeedback is simply, you could use a tool for that where there's kind of electrical impulses. that
Okay.
are connected. Yeah, little stickies that are attached to around that vaginal opening or around even the anal opening. And that can help to engage those pelvic floor muscles and again have that contraction. There are all sorts of insertable devices too that have apps that you can get on your phone. So as you squeeze and lift those pelvic floor muscles, you can have the person on the screen jumping over like a flower or jumping buildings. Oh, they have all sorts of fun things that you can do. Yes. But you also have to make sure that you're lowering it too. Chris, I've right. That's the back and forth. Not only do you want to squeeze, but you want to be able to relax and bring it back to neutral. So now you got to like duck under, a shooting star that's out there in the galaxy, if you're on a space expedition with one of these games or whatever else. So I really love that for people who are really visual. Yeah, so it can be a great tool to use.
Yeah.
Mhm.
Well, why not? I mean, you may as well have fun with it, right?
Absolutely.
Put in the work, enjoy it. I squeezed so hard, I jumped in Empire State Building.
Yes.
About squeezing and bearing.
Yes.
Now, as a fitness coach and strength training coach, one of the things I am just thrilled about with the Girls Gone Strong program, the world's first and leading women's health coaching, fitness coaching program, is that pelvic floor has received a lot of attention, entire module and a half onto its own. And one of the things that we like to teach at the beginning of each session with our clients is to do a connection breath, whereby if you're lying down on your back, and you can do it seated, you can do it in different postures, but lying down the back for one, you feel as the inhale, the natural lift of the lumbar spine to sort of peel away gently off of the floor. And then with that exhale, you compress the abdominal wall, and then you do feel that squeezing, that lifting up, both the front and the back, pulling in and lifting up. Or as we say in the yoga, the Mula Bandha, engage the Mula Bandha, which is right by the root chakra and the hip bones. And another expression I've heard is feel like you're squeezing your hip bones together. Now, but then one thing that says is that have your client try to hold as strong, strong, strong as they can, and then back it off slowly till they think they only have about 30% of the engagement, because you want to stay right in that range. So explain to us why we don't want a tight bearing down sensation, but enough of a core engagement that when we're bearing weight in a strength training class, we have pelvic floor stability and core stability.
It boils down to the abdominal pressure.
Ah,
It's all actually, this is what I love about the body and how it's all interconnected, right? So
yeah,
when you are taking a breath in, when you go to lift something, right, you're actually in pulling in air into your lungs, which actually acts on your diaphragm. And that diaphragm is going to push down on that pelvic floor from your abdominals, right? So if you're already engaging with that pelvic floor, you get this beautiful kind of esocentric kind of combustion right there in the middle
yeah,
in your core. But if you don't engage your pelvic floor muscles and create some stability, when you go to breathe in and that diaphragm descends, your pelvic floor is also going to descend.
right.
And that's then when you can add more weakness to the pelvic floor, more prolapse or urinary incontinence can happen as well.
Yes. So it's as if you're applying pressure to counter the pressure that's going to come in from the diaphragm just from a natural breath.
Correct.
I love that. That's a really great analogy or way of explaining it with that visual. And I've just learned something that I can share with clients when we do
Yeah.
strength training. Very good. Wow. So this has been such an informative conversation. I'm just blown away with some of the data, the stats, the issues that you have raised. And thank you for sharing with us that recent report as well on genital urinary syndrome in menopause and even in lactation. So important. I will be sure to link that in the show notes. Yes. So, what's one thing that women could be doing right now to ensure that they have good, strong pelvic floor health, no matter what their age?
Exactly. Again, it's just, I think having that appreciation and knowing that you have a pelvic floor, just like embracing it. This is what I'm going to work on. And if you have not had somebody evaluate your pelvic floor, make a call, like reach out. That I think is so important. Start advocating for yourself, empowering for you. One of the biggest questions I always ask my female identified patients is, what self care look like for you? What is
Oh,
something every day that you do for you? Most women are givers. We do everything for everybody else. But if you don't put that oxygen mask on you first, and then help others is not going to work.
True.
So, right. And I like to be that real person in the room with them and giving them the permission. And I think it again humanizes that we're all guilty of doing this. I fall guilty of doing it too, but I try as much as I can to practice what I preach and empower my women that you can do this. And it doesn't have to be big. What is 5 minutes that you can do, for yourself on a daily basis? It's a great place to start.
Right.
So that would be one of the things that I would do to go ahead and start engage in those pelvic floor muscles, and just even sit while you're sitting here listening to this podcast. I want you to think about, what does that look like to lift that pelvic floor, lift it to your belly button, hold it. How does that feel in your body? Where are you feeling that energy? Where is that going? And so again, having that connection to your body is so key with this process.
Yeah. Sometimes that sensation just feels like a gust of wind or a fresh breath coming up from the navel, or the vaginal area right up into the chest, into the throat. It's like breathing life and just raising that. Raising it
It's
up.
so energizing. So,
It
so
is.
energizing. I
Yeah.
will say the caveat to that, if somebody is a holder, if you know that you have anxiety, TMJ, or clenching, or hold, if you know you're holding, I know, if you're holding your belly, you already have a tight pelvic floor. So engaging in those pelvic floor exercises may not be as beneficial for you. You can do the opposite though. Let's go back to that diaphragm. The diaphragm is going to be your friend in helping to down regulate those pelvic floor muscles. So doing belly breaths, breathing in for, if you can breathe in for 8 seconds and kind of hold it and breathe out for 6. And
Mhm.
then breathing and kind of do that. We call it box breathing, right? But it's more rectangular breathing is what you're going to be doing. And so that can be super helpful then to unlocking that tension in your pelvic floor. But that's one of the other things that can be really helpful for individuals.
Amazing. Can you clone yourself,
Gosh,
Aleece?
I wish. Ah.
Everybody has a doctor just like you. You're so on board and engaging and empathetic, compassionate. That's exactly what our healthcare system needs. I am so thrilled that you were able to share with us your genius and that we can shout this on the rooftops and get it out on the airways. It's brilliant work you're doing. Thank you so much for sharing. And I'll be sure to get all of those important links in the show notes, including where people can find you. So tell us.
Yes. So I have the Fosnight Center for Sexual Health in Asheville, North Carolina. So you can go to our website, which is just fosnightcenter.com. If you wanted to follow us on Instagram, we're at Fosnight Center, or myself, which is at SexMedPA.
Ooh, I like it. That one will be
Okay.
so good. Make sure that's all in the show notes. Thank you so much for your brilliance, your time, your energy, and really shifting the way we think, act, and treat menopause.
It has been my pleasure. Thank you so much for having me.
If today's insights resonated with you, I'd love for you to be a part of our growing community of menopause disruptors. Hit that subscribe button wherever you're listening right now. And if you know someone who can benefit from these conversations, please share this episode. Sometimes a simple act of sharing can be the first step in someone's healing journey. And hey, if you're ready to take the next step in your menopause journey, I'm here to support you. You can find all my services, including my comprehensive menopause intelligence digital course, one-on-one coaching programs, and workplace education services at mlcoaching.com. It's in the show notes. Want to stay connected and get regular doses of menopause wisdom? Follow me on Instagram at Menopause Disruptor Podcast, where I share tips, insights, and real conversations about navigating this transformative phase of life. Let's continue to disrupt this menopause conversation together. Remember, midlife should be the best life, and it will be. Namaste.